done, and you can see that the significant reduction in the component of CV developed of the first part of the year, 26%, energy of 21. And this energy of 21 means that it has been 1% of the CV gap. And it was very tolerated in patient with or without diabetes because this trial, the fluid patient was non-obesity, we had this, we showed equally beneficial response. So, with that, what we are trying to do achieve, whether giving a combination of the kappa protein because in a sexual disease can address the dual concerns of glycemic control as well as the cardio risk reduction. It has been across all the baselines when you're giving extra and kappa combination, when you're comparing with the kappa metformin with Dr. Sundar Kumar alluded to. Almost depending on the baseline HbA1c in the reduction of the HbA1c from the baseline when you kappa or when giving the sexa plus metformin, but in the kappa plus metformin, the higher baseline value of N, there was much more reduction in number 2. While in this group of subset of the baseline HbA1c was 7.5. So this is a meta-analysis of a huge 58 RCTs involving more than 30,000 patients, and they have shown the success rate is the most powerful reduction in the combination usage. In the combination usage, you can see the most powerful or the efficacy in terms of reduction. This was the outcome of the meta-analysis involving more than 30,000 patients. Glycemic control was as good as compared to insulin target without hypoglycemia. And also it led to the significant increase in the SGLT2, so again a pleiotropic effect, and also a significant in triglyceride that either used alone. Apart from that, they have shown that they also reverse the microtubule hormone or microtubule micro when we are doing the SGLT2 inhibitor along with the saxagliptin, and saxagliptin alone has shown a decrease in the progression of the diabetic nephropathy. But the important point here is that because we see a lot of side effects when we're using SGLT2, in a combination we see very little of the genital tract infection, and I still remember Dheeraj was initially with his tweets were first to publish that 21% incidence of genital tract infection with the SGLT2 use alone. And with the combination of SGLT2 and the DPP for inhibition, very less number of patients coming with the GPI infection. Probably the DPP4 inhibition, because there are certain enzymes on the fungi and the DPP4 inhibitor inhibit those fungi and then causes the genital tract infection. So, this is my last slide. Finally, there is a concern that with heart failure, it was very common talk of the town about the saxagliptin. But if you think, if because the trial was avoided a bit earlier, if the trial would have been sustained for a longer period of time, the cost, the mortality was less, number one. And because of the initial improvement of the patient who were elderly, your initial hiccups about the heart failure, increased in the heart failure, with the saxagliptin. So that has been removed. And they are shown that if you have basically prolonged the time, as our this to 1.27. That means because it was terminated within 2 years, some people were talking the saxagliptin was causing increase in heart failure. So that was the again showing the very good efficacy of the saxagliptin. And last but not the least, that is shown to have some impact on the energy structure and the function in patient with type 2 diabetes and the heart failure, which was a result of the major heart failure study. I am not going to dictate the major, but only to tell you about that the primary endpoint, the index was improved while using the and it also translates into reduction of the CVD. So dear friends, the sector development plus the standard care, which was long inferior to the placebo or did not demonstrate any significant relief in the LDG primary endpoint. The effects of sexual development on the cardiac structural changes compared with placebo, the standard care major catch-up trial did not demonstrate any cardiac structural or biomarker changes indicative of worsening heart failure, which was the trial in patients with type 2 diabetes who had established symptomatic heart failure. So the concern is over, our anxiety is over, and we are thank you.
Thank you, sir. Thank you very much, sir, for your comprehensive talk. And if we have any questions from both the speakers, we can have some questions. I think everybody has understood the topic here.
Everybody is really digesting their lunch.
Thank you.
Right. With that, we come to the end of the first session on diabetes. I would request the speakers to kindly join me once again on the stage. May I request the speakers?
Dr. Mamu, please. Dr. Mamu. Dr. Sridhar Kumar. Okay.
Sir, this will take just a minute. I would request Dr. V.K. Gupta to kindly come on stage and just say the speakers and the chairperson. Professor Sridhar Kumar, I don't see. For the next part of the diabetes session, I'd like to invite on stage the chairpersons for the coming two talks. The two talks will be given by Dr. Dinesh Kapoor and Dr. Monashi Salu. Before that, I will invite on stage our chairpersons. First, I will invite on stage Dr. Paras Agarwal. Dr. Paras Agarwal is a senior physician working in Italy. They don't have 22 years of clinical practice, and he has multiple publications in national and international journals. But he also happens to be smartest if he is senior is something at his office. Rajiv Gupta, ex-president EDPA, consultant physician practicing in ECT for the past 35 years. He is also co-founder of the Catholic Code. Dr. Naveen Akil, senior consultant physician at Max Super Specialty Hospital, Patna. And Dr. Meenakshi Jain, she is working as a senior consultant and diabetologist at Max Super Specialty Hospital, Patna.
टाइम 12 मिनट कितना दिया वो 12 बोला था
It's my. It's my pleasure to invite Dr. Dheeraj Kapoor very much respected. Who is a well-known endocrinologist to this August audience. He has been speaker here also. He's head endocrinology department under his hospital, Gujarat, and he's done his DM in all high, his own 60 publications, and he is the editor of monograph on emergency therapy in nephrology, on medical therapy in diabetes, and of course, the editor of both therapy in fitness. He's on the board of several journals and involved in numerous clinical trials and therapeutic research. We will be talking on a topic called multifaceted approach to type 2 diabetes management. Dr. Neeraj.
Thank you so much, sir, for that introduction. And I've been asked to speak on the multi-factor management. One must understand at the outset that diabetes is not normal. It's a cluster of disorders. We may call them comorbidities, maybe hypertension, obesity, but I think they are the seedlings for diabetes. And of course, hypertension, dyslipidemia, and dysglycemia go hand in hand, and therefore, the management has to be multi-pronged. And any drug which can help us address that would be more than welcome. So one must understand that microvascular complications to a major extent depend upon disease. But the macrovascular complications, mind you, cardiac events are the major killer. They depend on the testing to a major extent. Others also are significant contributors like the dysglycemia and hypertension. The ticking clock hypothesis means that the CVD morbidity starts at the IGD stage, not diabetes. So if you have to address an issue, it has to be weight, it has to be a multi-faceted approach to management of diabetes. So this slide would explain things better. That if you look to your extreme right, if you reduce HbA1c by 0.9%, what you achieve is maybe a 2.9% reduction in mortality. But BP loading as little as 4 millimeters, and that would keep us 12.5% ahead. And also LDL, 20 milligrams is not a big deal to reduce. It will put us around 9% ahead. So instead of being glucose-centric, one has to be maybe hypertensive approach as well, and the lipids. Steno trial or well-known trial, someone may argue just 160 patients, granted, but that at least set us aside that look here, if you manage holistically, you could have better outcomes in patients with diabetes. Lifestyle modification, an oft forgotten concept in the exuberance of writing drugs and treatment, we do not consider the lifeline, and that is the lifestyle modification. And obviously, control blood pressure, limit platelets whenever required, manage lipids, and of course, glycemic control. It goes without saying. So we've heard about different diffusions. Now, what about the GLP-1 receptor? Here, the molecule acts in multiple ways. First of all, beta cell neogenesis and atomization. Now, proven in rodents and mice, not so much in humans, but still, it does give pressure to the pancreas, and that is a well-known fact. Increases insulin, decreases glucagon, which means reduction of hepatic glucose output. Also, delays gastric emptying and reduces satiety. Now, why is that important? In our context, we know that we Indians consume around 64% of calories in the form of carbohydrates. The STAR study says that. So, if you reduce food intake, indirectly you reduce carbs, you reduce hyperglycemia, you reduce lowering of triglycerides, and therefore small dense LDL and lower strength. So this is the whole cycle which goes on. At the level of the blood vessels, well, reduction in the smooth proliferation, and the lipids also become better. The the rupture doesn't happen as frequently as it does in those without. ADA, very, very clear that if the patient is having CBD or CKD, injectables, these are drugs. We know that CBD is the major killer and CKD, as it runs its course, is the most expensive of diabetes complications too. So CKD and CBD have to be addressed, and this class of drugs would do exactly. So for those on injectables, can we choose these drugs? Well, so we have to be careful. The patient should have type 2 diabetes. The sugars should not, fasting more than 250, random more than 300, that means it's 10, 9.9, no. So if that is the case, then obviously go with insulin. But otherwise, if with drugs, with insulin, you can't keep targets, then GLP receptors are the way to go. We have many of them now, once a week, once a day, so on and so forth. So what about the once a week approach, the weekend drug as they call it? We must understand that these drugs benefit cardiac, benefit kidneys, but the main aim is to control the sugars. That is what they are meant for. The other are just offshoots of the medicine. So if you compare Duram and Dira, well, it's almost similar reduction in HbA1c, glargine, far superior, and as an add-on to insulin, again, this drug fares better as compared to glargine. Now, this is a very important slide. Just focus on the middle ground. The reduction in weight as compared to glargine is 3.3 kilograms. So 1.87 going down with Dula, 1.4 going with glargine, which means a net of 3.3. Now, what is the importance? The importance is that if you put on 3 kilograms of weight in the process of going down 1% HbA1c, you actually nullify the benefit. Lose 1% HbA1c, go down 3.5, you are in the net negative. So any drug which causes weight gain, which controls sugars, is a welcome addition. Now, the CVOTs, because cardiac is the major killer, and so these trials have an uncanny resemblance to the dapagliflozins. In dapagliflozin, had cardiac issues. Dapagliflozin around 66, and dapagliflozin 26 or did, and the rest. So similarly here, we know linear trial did very, very well. But if you consider dulaglutide, most patients did not have the cardiac events. The glargine trial we see. If you look at the male-female ratio, again similar to what we see in our daily OPDs. And the results, 13% linear trial, 12% with dulaglutide, which means almost similar benefit in terms of reduction in cardiac value. So those patients not having established CVD, still we saw benefits in these patients. Now this is a very, very interesting slide, and I wanted to put it myself could not comprehend it. This shows there is a significant benefit with Dula. You see the line to the left of unity. If you see the entire population, but if you see both with and without CV, it's a good reduction, but still it is crossing the line of unity. So I'm not too sure whether that 0.02, which I showed, where it came from, but this is slightly confusing. Reduction is very, very good, but technically speaking, it did not achieve superiority. But nonetheless, it did show that even in patients without CVD, there is some amount of reduction. Side effects, well, hardly any. It reduced cholesterol by around 2 mg/%. Blood pressure, again 2 mg of mercury. it did increase the heart rate by 2, and that is why some authorities do not prefer to use these drugs in patients with prone to heart failure, because even a slight increase in heart rate could tilt the balance. Microvascular, both in terms of retinopathy intervention and fall in GFR, better. There was reduction in conversion from micro to macro. However, from normal to micro is not possibly because the time frame of 5.4 years was not sufficient to judge the progression from normal to microangular. So if a patient had GI side effects, which patients do, small frequent meals, less fatty meals, and possibly a PPI would help the matter. So far from being concentrated, you have to be a holistic approach. So not controlled multiple OADs, still struggling with HbA1c, weight gain is a concern, cardiac risk is a concern, even if CPD is not established. Looking for a single therapy once a week, this is the way to go. So to conclude, moving beyond glycemic control is the way to go now. We know type 2 diabetes is complex. It's a combination of metabolic issues, microvascular, macrovascular. Treatment will come a long way in getting drugs which do not cause hypoglycemia, which also have extra glycemic benefits. GLP-1